there is. Good morning, everyone. We will start the session in sake of time as we have multiple abstracts lined up in the session. I'm Cemal Yazıcı from University of Illinois, Chicago. I will co-chair this session with Dr. Guy Groblowski from University of Wisconsin. So we will start our first talk with a keynote speaker, Dr. Matthias Thur. He is currently the president of European Gastroenterology Association and previous secretary of the Pancreas Gut Club in Europe, and he was also program director of Pancreas 2020. He is working with the pancreas for many decades and learned his MD from University of Hamburg in Germany. Since 2007, he has been professor of gastroenterology and hepatology at Karolinska Institute, and he received the Lifetime Achievement Award of European Pancreas Club in 2023. Current areas of interest are chronic and autoimmune pancreatitis, pancreatic function, IPMN, familial pancreatic cancer, early pancreatic cancer, and liquid biopsy. And he is going to talk about autoimmune pancreatitis, current guidelines, and emerging therapies. Dr. Lowe.
Kemal, thank you for a kind introduction, and I thank APA for inviting me to this fantastic meeting. I haven't been with APA for a couple of years. I have the pleasure to present to you autoimmune pancreatitis, the current guidelines and emerging therapies. And these are my disclosures. It all started actually, the guidelines that is, with a consensus which happened in the United States, but in Hawaii, so to say, under the leadership of APA, IAP, the Japanese, and then also the EPC, quite some time ago. It was the first consensus. It was a little bit kind of complicated, but still something we use in academy. The entire field of autoimmune pancreatitis then became a push because most of the autoimmune pancreatitis, that is the type 1, is part of the so-called IgG4 related disease, where the pancreas and the bile ducts play a very important role, as you will see. And this was something which is driven by rheumatologists. It's a quite interesting experience, for me at least, as a gastroenterologist and pancreatologist, to immerse in that world where things are a little bit different than we are doing it. And I'll come to that a little bit later during my talk. The next step then is when we issued the first evidence-based guidelines from Europe, the United European Gastroenterology. But on the review panel, many of our friends around the world from the United States and Japan were reviewing the guidelines. They also appear as also in the appendix. From this we deducted a rather simple diagnostic scheme, as you can see here. And I will walk you through this now with a couple slides also from the guidelines. Although this is not official part of the guidelines, I will follow the HISORT criteria, which were originally established by Suresh Chari. It's a hilarious acronym, I should say. And if you keep this in mind, you will never forget anything to do with a patient who may or may not have autoimmune pancreatitis. With regard to the histology then, we don't know a lot about the etiology. Obviously, it's an autoimmune disease. I'll come to the autoantibodies, which were already mentioned yesterday a little later. But then, very soon after the T cells, the B cells are involved. And then in the pancreas, obviously, this creates, via TGF-beta mostly, a fibrosis. And this is the overarching, really, histological feature in virtually all of the organs. This huge so-called storiform fibrosis, and then the appearance of these quote-unquote stellate ducts, both in the bile duct and the pancreas. And then on surgical pathology, as you can see here, this really enlarged pancreatic duct. Oops, it's not showing. Anyway, And if you have a nice 4-phase contrast-enhanced CAT scan, you can see both the pancreas as a swollen gland, and then the enhancement, as you can see here, in the distal bile duct and the lesions in the kidney. So there's a pathognomonic appearance, and an educated radiologist will be able to establish that diagnosis on first sight, so to say. In the guidelines, we also looked at that, and in these pictures which are here, you can see the other features. The rim, the appearance was called by our US colleagues a German Bratwurst, and I think that's quite a nice depiction of what you see really in the pancreas in patients with ardent pancreatitis. Now, with regard to the serology, it looks a little bit different. We all have IgG4. This was the hallmark paper by our friends from Japan 15 years ago already. But in ardent pancreatitis particularly, it is not elevated all the time very highly. We have learned that even a slight elevation of IgG4 can be suffice to establish the diagnosis if other features are there. And there is a discrepancy, as you can see, between the frequency of the affection of the glands, pancreas and bile ducts the most, and then the positivity, say if you have ardent pancreatitis, of IgG4 in the serum, and then even in the tissue. So IgG4 is helpful, but it's there are even cases we discussed when we came up with the international consensus diagnosis criteria, that there are some cases where the IgG4 in serum may be normal, and still you have an ardent pancreatitis or an IgG4 related disease. Good. Then we looked into that, and it was mentioned actually yesterday in the session about the exocrine pancreas and diabetes, the autoantibodies against carbonic anhydrase type 2 and lactoferrin. They're positive, mostly, I should say exclusively, in type 2 ardent pancreatitis, which is linked to IBD, but not so much in the typical type 1 ardent pancreatitis. The only antibodies which are confirmed by independent studies are against SPINK and trypsinogens, but there are no commercial tests available, at least not in the US and Europe. For SPINK you can measure, there's a test out in Japan. So we are still in the search for good markers for ardent pancreatitis and IgG4 related disease as a whole, which are not available as the diagnostic tools these days. Other organ involvement. This is a PET scan of a patient, and I'll come to that in a minute again, which we have learned to use, because this is what we have learned from the rheumatologist really. There's a baseline. You have to look where else the disease is manifesting itself, and there are quote-unquote hidden places you couldn't think of, and they escape the ordinary diagnostics. It is important to note that the pancreas and the bile ducts are in all of the 4 major patterns of IgG4 related diseases present. That is to say, ardent pancreatitis is one of the diseases which demarks, or one can almost say defines, IgG4 related diseases. This is why we actively should search for other organ manifestations in these patients, because then obviously other disciplines need to be involved. I used to call the appearance of the IgG4 related disease in the pancreas and the bile ducts the pas de deux, because it resembles this kind of thing on the papilla. I just, preparing this lecture, came across a very nice paper from Beijing, where they looked for not only the FDG PET but also the FAPI PET, which we are using for the diagnosis of pancreatic cancer, by the way. And this seems to be an even better diagnostic tool to diagnose IgG4 related diseases. They even claim that there is an index between the FDG PET and the FAPI PET, so you can have a more proliferative and more fibrotic type. This needs to be determined, but certainly the FAPI PET, or say a PET at all would be a very good idea to do in a patient where you suspect IG4 related disease, that is in our case here autoimmune pancreatitis type 1. Now to therapy. The guidelines here say obviously steroids are the number one choice. This is still true. And we have to reconsider a little bit maybe the dosing. I just happened to be in the session on the young pancreatologists, or how you do to kind of motivate people. I was running the Pancreas 2000 program for 15 years, and this is something where you gather young to-be pancreatologists and then you do studies. This is one of them, sampling some 1,000 or so autoimmune pancreatitis patients and then doing an analysis. As you can see, this is a retrospective study, but I mean, if you have that many patients well documented in a database, then you can really ask serious questions. And one of the questions we asked here is, how do you treat, or how those patients were treated and what was the outcome? And there were some surprising data coming out of this. Number one, less is more, or is at least as effective as the ordinary high-dose steroid therapy, which we used to apply in most of our patients. Number one. Number two, if you have a shorter induction period, this is again equally effective as a longer induction period of the full strength, quote unquote, of the steroids. And obviously with all the side effects of glucosteroids, this is something which is really important to expose those patients not for a longer time to steroids, certainly at the higher dosages. Then going further in the discussion, you can use other steroid-sparing drugs, but again we learned from dermatologists quite quickly that you should switch to B-cell depletion therapy. And that is something I think which is really a big step forward, because most of those patients will respond and will respond very well to B-cell depletion therapy, in this case CD20. And then if you look a little bit and kind of make yourself familiar with the immunology behind B-cell depletion, then there is obviously the CD19, as you can see here, covering a larger spectrum. And this led to a study which we conducted called the Mitigate study, where after induction with steroids, we randomized the patients to a CD19 antibody, as you can see here. And this was published earlier this year. And there were virtually almost no flares in patients with IG4 related diseases. And mind you, the majority, I will show you that in a minute, had autoimmune pancreatitis 2 compared to the placebo. So here we have a drug which is by now approved by the FDA for the use in IG4 related diseases, which really is extremely effective in preventing a flare in IG4 related disease, including the pancreas. Now, Emma Calver from Oxford did a very intelligent thing. She created a virtual study taking original data with rituximab B-cell therapy and then ipilimumab B-cell therapy and compared them. And apparently, in this study, which was published and presented as an abstract at the UEG week 4 weeks ago in Berlin, the CD19 blockade B-cell depletion is even better than the CD20. So that is really something which we can use in the future, particularly in this country. Now, with regard to the pancreas and the bile ducts, I presented this at EDW, also here in San Diego on the other side of the lake or the bay here. The results look even better compared to the entire group, that is to say, both in the pancreas and even more in the bile duct manifestation of IG4 related diseases. This drug really prevents a flare, that is a recurrence of the disease. So that is very good news, and virtually the first drug we have to treat autoimmune pancreatitis type 1. The open questions obviously are, do we really have to do PET scan in all of our patients? This is to be determined. And then, as in IBD, should we do a step up or step down therapy in patients with IG4 related diseases, particularly in autoimmune pancreatitis. By the way, there will be a lunch seminar of Dr. Singh of Johns Hopkins who will dive more into the Mitigate study and the results from that study. The last piece I would like to talk about is monitoring. We also looked into that after we published the European guidelines, asked a group at the UEG platform joining, and many joined immediately. You can see this here. The study also collected many patients with IG4 related diseases and autoimmune pancreatitis, and the results is sobering, I should say. The adherence to the guidelines is in some cases really below a threshold which you can accept. As you can see here, the red also, so that is not very good. And we also did the same thing, both us and the Dutch pancreatitis study group in chronic pancreatitis, there it looks much better. That is also saying that we are not as familiar with autoimmune pancreatitis as we are with ordinary chronic pancreatitis. The last word on the sequelae of autoimmune pancreatitis, going to the latest European guidelines in pancreatic exocrine insufficiency, there is in these patients after some time both an endocrine and an exocrine insufficiency. And this is where we have to follow up these patients very, very carefully. I haven't even talked about the cancer risk, which is another thing we have to learn about, whether this is really a threat or just a coincidence. Summing up, I think there is a rather easy now diagnostic pathway to establish the diagnosis of autoimmune pancreatitis as part of the IG4 related diseases. And then for the therapy, I think steroids are still the number one, less dosing, and then the B-cell depletion therapy. In this country, you're lucky that the drug is approved by the FDA already, so that is something you might consider. With regard to the guidelines, this is the app you can download for freely, both for the Android and the iPhone, which also incorporates the guidelines for the IG4 related diseases, chronic pancreatitis, and pancreatic exocrine insufficiency. My last slide showing you a cordial invitation to the EPC next year, which will be together with IAP in Istanbul. And then the year after, we will come to Stockholm, my hometown, for another EPC. Thank you very much for your attention.
The talk is now open for questions, if there is any. Maybe I will ask you one question. So with the now the data showing the efficacy of CD19, CD20 being quite well, how early, at least in Europe right now, they start the CD19, CD20 based therapy?
As I said, we have learned from the rheumatologist to apply. If there is a flare or recurrence, we go from steroids to rituximab immediately. This is off-label use, obviously, but tolerated in most of the European countries. Now, with the new drug, which will eventually, rather soon, I believe, approved also by the EMA, the situation is a little slightly different because in Europe, this is bound to the different countries. Say in Germany, if this is approved, you have to use it. Okay. In other countries, such as in Sweden, my home country, the authorities may decide, okay, it's too expensive. You have to get approval by a patient-by-patient kind of on a patient-by-patient basis, right? So we have to see how this is going to play out in Europe. Again, I mean, you're lucky here in the United States because the drug is approved and you can use it.
There is microphones on each aisle.
Hi, Suhail Hussain from Stanford. Thank you very much. So informative. I wanted to ask, being a pediatrician, that often we will see what has previously been called the type 2 AIPs, in children, and often they're steroid responsive without the need for further immunosuppression. Are there guidelines that UEG have come out with for that subcategory?
No, we haven't done that. We just published, I believe, last year our experience with type 2 autoimmune pancreatitis. You're quite right. They respond quickly, and sometimes it's the other way around. They get some kind of immunotherapy for their IBD, ulcerative colitis, or Crohn's disease, and then, by chance, the pancreatic affection is discovered, and then it would not need extra therapy. Okay. Why are we following those anyway? And this is exactly what I said last. They are also prone to pancreatic extra insufficiency in the long run. So even if, say, the pancreatitis, the autoimmune pancreatitis, is not prominent in these children who have IBD, right? You need to follow these patients up.
Thank you, Matthias, for that illuminating talk and addressing a number of issues which are very important. Thank you. Can I ask you to give some guidance about dosing? You indicated that the high doses of steroids are no longer necessary, and clearly it's going to depend on response, I guess. Can you just give some?
We started out with 0.5 milligram per kilogram body weight.
Sorry, I can't hear you.
Sorry, I said we started out with 0.5 per kilogram body weight, and this can be reduced to 0.3. Okay, as a rule of thumb. That is to say, in a 70 kilogram man or person, I should say, you don't need to take, say, 40 or 50 milligrams. 30 may suffice. Okay, so that is. And we have another paper out which came out a couple of weeks ago from the same study, where you can even titrate this according to some factors. Okay, I haven't dwelt on this anymore, but yes, you can certainly be effective with less steroid. Period, which we thought to be 4 weeks, can be shortened to 2 weeks and then tapered down.
Yeah, thank you.
Thanks very much.
Okay, thank you.
Okay, now we're going to switch to abstract talks. Each are 10 minutes. There's 10 abstracts to be presented. We're already 10 minutes behind, so we might have to cut the questions a little bit short. The first presentation is by Ji Wu it's entitled Macrophage Piazo-1 Sustains Pancreatic Stellate Cell Activation Through PNPLA3 Mediated Lipid Metabolic Reprogramming. She is from
Peking Union Medical College.
Okay, sorry.
First, thank you to our APA organizer for the opportunity to be part of this project. Chronic pancreatitis is a progressive and irreversible fibroinflammatory disease of exocrine pancreas, characterized by extensive loss of parenchymal tissue and persistent chronic inflammation, eventually massive fibrosis without specific therapy. Fibrosis means that PSCs are persistently activated, leading to an increase in ECM and enhanced stiffness. The increased stiffness in return promotes the activation of PSCs. PSO1 is the most highly expressed mechanism in the pancreas which can sense stiffness. making it a promising potential target for breaking this vicious cycle. To date, there are 3 articles regarding PS1 and pancreatitis. The first article demonstrated that PS1 in SC cell is a mechanically activated ion channel and mediates pressure-induced pancreatitis. The second article revealed that TRPV4 channel opening mediates pressure-induced pancreatitis initiated by PS1 activation. The third article showed that PS1 mediated stellate cell activation causes pressure-induced pancreatic fibrosis in mice. And PS1 is highly expressed in macrophages, and the interaction between macrophages and PSCs plays an important role in fibrosis in CP. Additionally, a study has reported that specific deletion of PS1 in macrophages protects against the progression of liver fibrosis. So, we aim to investigate the role and its underlying mechanism of PS1 in macrophages in sensing the increased tissue stiffness and sustained fibrosis during CP. Basically, we approached this using three main methods. First, we create a malloid-specific PS1 deletion mice, verified the knockout efficiency. Second, we established the CP model by injection of thurine 3 days a week for 4 weeks. And finally, we set up an in vitro co-culture system with macrophages and PSCs. Next are our research results. First, we evaluated the pancreatic tissue stiffness of patients with CP and healthy individuals using EUSEG technology, and found that stiffness of pancreas was increased in patients with CP. And then we performed the PS1 staining on the pancreatic tissue of CP patients and mice, and observed that PS1 is upregulated in both CP patients and CP mice. And then we induced the CP both malloid-specific deletion mice and the control mice. HE and IHC staining shows that knocking out PS1 in macrophages reduced the pancreatic damage and elevated fibrosis. And qPCR data supported these findings. Let's lead us to our question: how does stiffness affect macrophages polarization via PS1 on macrophages? IHC shows that knocking out PS1 affected macrophages polarization. Specifically, we saw on few M2 macrophages and more M1 macrophages. And to confirm this directory, we isolated BMDMs and polarized them with found deleting PS1 inhibits them to polarize into M2 macrophages. We cultured BMDMs on different stiffness. We found that softer matrices also inhibit macrophages polarization, and the combined effect of PS1 knockout and reduced stiffness stimulation results a more significant inhibition of macrophages polarization. So, stiffness sensing by PS1 is required for macrophages polarization. So, how does macrophage PS1 sustain the activation of PSCs? To answer this, we turn to our co-culture model. We collected conditional medium from M1 and M2 macrophages for treating PSCs. We are including TGF beta cultured PSCs as a positive control. Our results show that M2, not M1 macrophages promoted PSC proliferation and sustained the activation of PSCs. Next, we cultured and induced the BMDMs from PS1 knockout and control mice, collected medium from M2 macrophages and used it to culture PSCs. We found the increase in cell numbers and alpha SMA expression caused by M2 medium was significantly reduced when PS1 was knocked out. This shows that PSO1 is indeed necessary for M2 macrophages to sustain PSC activation. To follow investigate the mechanism underlying the changes in activated PSCs, we performed the RNA-seq analysis on PSCs cultured with medium from M2 and M0 macrophages and found that lipid metabolism was significantly upregulated in activated PSCs, with the most prominent changes observed in PLPLA3. And PLA3 is a key enzyme involved in triglyceride metabolism. Let's bring us to the summary of our findings. Macrophage-specific deletion of PSO1 limits fibrosis in CP and inhibits M2 macrophages polarization. Stiffness sensing by PSO1 is required for macrophages polarization. M2 macrophages sustains PSCs activation through PNPLA3 mediated lipid metabolic reprogramming to promote CP. Finally, I'd like to sincerely thank you, Professor Wen, for guidance, and all members of Wen Lab and our collaborators for their help. Thank you for your attention, and I will help you take questions. Thank you again.
Hello, Dr. Wu. Thank you for your wonderful speech. Your study presents compounding in vitro data using conditioned media and co-culture systems, which strongly suggests that M2 macrophages activate PSC through secreted factors. But to firmly establish the direct causal link in vivo, I was wondering about a potential intervention to specifically deplete M2 macrophages in an established chronic pancreatitis mouse model. Would you expect to see a corresponding downregulation in PSC biomarkers like PNPLA3 and ultimately a reversal of fibrosis?
Thank you for your question. This is a wonderful concept that could provide more evidence to support the importance of PNPLA3. We are conducting this experiment and awaiting the analyzed data. And we also hope to find the conditional medium from M2 macrophages with myeloid specific PSO1 knockout can reduce the expression of PLPLA3. We also hope so. Thank you.
Thank you for your answering. I'm looking forward to the results too.
Thank you.
One more brief question, please.
Very quick, thank you. My question was already asked about the therapeutic intervention, but I just wondered, in your PSO-deleted macrophages, do you also see a change in what other things they secrete, which are known to activate stellate cells anyway, like PDGF, TGF-beta, and so on?
TGF-beta?
Or what are the other factors that are not secreted if PSO1 is deleted from your macrophages? Because that could also explain why you're seeing, in addition to the lipid metabolism. Have you looked at that? Are there any other factors that are inhibited? We can talk later then.
Okay, thank you. Thank you.
Thank you. Our next speaker is Mahia Fagih from Johns Hopkins Medical Institute. The title of her talk is Feasibility and Preliminary Effectiveness of Electrocutaneous Analgesia for Refractory Abdominal Pain in Chronic Pancreatitis, a pilot study.
Good morning, everybody. I would like to thank the moderators and meeting organizer for inviting us to present our research. This study was supported by young investigator in pancreatology branch. I'm just trying to see. We all know that pancreatic pain affects approximately 80 to 90% of patients. Is the primary reason patients are seeking medical attention. It's constant and severe pain as associated with lower quality of life, higher rate of disability, hospitalization, and opioid use. However, mechanism is poorly understood. Here's the current therapies for managing pain. It spans from therapeutics, intervention, modulators, but however, why do the current treatment fail in chronic pancreatitis? We all know that pancreatic pain characteristics are highly variable in CP patients, and it's like the locations matters. We all like traditionally think that the location of the pain is in epigastric. However, when the pain is becoming more chronic, the pain could be anywhere. The pain patterns are very variable. The Dutch pancreatitis group showed that 61% of patients had at least one change in their pain profile over 47 month follow-up. Also, the intensity variable, even by in 5 minutes, if you ask the patient, intensity can changes. Also, the pain does not correlate with any morphologic finding and evidence, even in advanced chronic pancreatitis. And how do we know that these responses to endoscopy and surgical therapies are not to sham? The sham response rate across a range of all conditions associated with chronic pain is it could be as high as 60 to 70%, and it's been shown in the recent study that our colleagues did comparing ESBO and ERCP to the sham arm, and in a 24-week follow-up, they showed there were no differences between ESBO plus ERCP versus the sham arm. But how do we know that direct nerve-related therapy works? If we are thinking about the hypothesis and mechanism that are involving chronic pain, and any of this mechanism are being addressed by direct pain, any of this direct pain intervention, then we definitely can solve this problem. Some of the mechanism of the action they're thinking about are gate control theories. It can be involving A beta fiber activation. It could be endogenous opioid release, C fiber signal modulation, and descending inhibition. Also, it could be anti-inflammation effects of the vagal pathway. Here's some of the electrocutaneous analgesics, and specifically today we're going to talk about the scrambler therapy. And what is a scrambler therapy? A scrambler therapy is kind of, as you can see the device on the right, it's kind of an electrocutaneous analgesics, and it's giving the substitute the pain information with synthetic no pain information with 5 artificial neurons to capture the C fiber. There are digital synthetic of the different kind of action potentials that scramble with chronic pain signal. It's been FDA approved for acute and chronic pain. The only downside to it is the device is expensive. The cost is currently around 65 to 70,000 per unit. The use is restricted to trained physician or under supervision of a physician. But the good thing is there are not many side effects. And also, one other thing is the only contraindications is either being pregnant or if you're having the implantable devices such as like a heart stent, or if you're having the spinal cord stimulation. Also, if you have a seizure disorder, this is another absolute contraindication to this therapy. This is very important. This is not TENS. When you're comparing, like everybody thinking this is a fancy TENS, but this is not a fancy TENS machine. When you're comparing and looking at the TENS and a scrambler therapy, there are very different in terms of mechanism, what kind of fibers there, each one of them are affecting, and also where they put it, and the mechanism is totally different, as you can see in this table. A scrambler therapy application is very easy. Actually, it's the only thing very similar to the TENS. You can use up to 5 electrodes placed approximately and distally to the side of the pain along the dermatomes that involve. But only different with TENS is you are putting it and giving a non-painful sensation between the 2 electrodes. You can magnitude the electrical stimulation and increase it every 5 to 10 minutes. And you can be increasing it until the pain relief or the patient reach their maximal threshold. Each treatment sessions can last 30 to 40 minutes, and it's better to do it in consecutive days. There are several studies in other painful disorders, and it has been shown that it's very effective. 80 to 90% of patients have a favorable response with a minimum directly important difference of 1 point to 11 point lasting 3 to 9 months. And sometimes they require a booster treatment that with 1 or 2 sessions they can extend the pain-free period. Also, it's shown that scrambler therapy decreases pain, improve pain tolerance, and regulates serum neurocytokines in low back pain patients. Also showed that it can change the cerebral blood flow and inhibition of the nociceptors. But it has never been shown any studies that test this in abdominal pain or chronic pancreatitis. So we did a pilot study of scrambler therapy for painful chronic pancreatitis. The aim of the study was the feasibility study as to determine whether scrambler therapy is feasible and effective treatment for refractory chronic abdominal pain patient with chronic pancreatitis. We looked at patient recruitment. Can we recruit sufficient number of eligible patients for the study? And patient adherence, all the patients going to adhere with the number of the scrambler therapy treatment per protocol, and also retention if they are going to continue and follow up with us for 3 months. Also, we looked at the treatment efficacy and if it's whether it's effective or not. This is the study design. The page, and on the left side, you see how we place the electrode. This is a young gentleman with abdominal pain with chronic pancreatitis. We are planning for the scrambler treatment up to 10 sessions. Prior to the scrambler therapy, there were questionnaires, sensory testing, EEG, EKG, and pain surveys. And also then patients follow up to 3 months. Here, as we looked at the feasibility progression and also the progression steps towards the next step would be another like a larger trial with this go, amend, and stop traffic light assessment. And we approached 25 patients, and as you can see, we were able to enroll 19 patients, and 19 patients continued the treatment, and 15 patients completed their recommended sessions. Among those, we had 2 missing data at the 3 months follow-up, but we were able to communicate and get the VAS score and all the primary outcome from them. This is some of our feasibility and pain outcome. As you can see, opioid use as baseline decreased from 42% to 5%. Pain score at baseline decreased from median of a 6 to 0. And this is the pain score trajectory over time. There's every dot representing 1 patient, and every line is showing the patient's decrease, the VAS score from the baseline to day 15, 1 month, and 3 months from the treatment. Here, the similar pain score showing in the box plots, the median of the 5.5 at baseline that decreased to a median of a 0 at 3 months. Here is a number of treatment sessions for each patient. The blue lines are showing the patients who completed the recommended treatment. And by recommended treatment, meaning that they've been pain-free for 48 hours before we are saying this treatment is effective. We have a couple patients which shown in red that they did not complete the course of a treatment and they stop while they're still having pain. Here are some of the reasons why and barriers of the enrollment and why the patient did not complete it. On the top section are the reason why the patient did not continue. And the bottom one is the reason patient why they did not enroll. And mostly because of some of those contraindications, like the patients having seizures disorder, or they were not interested in participating. And the most like a common reason for the patient not want to continue was they were living far away and it was very hard for them to commute every day for, let's say, 3 hours each way to get 1 hour treatment. This was, our result was very promising. It was very feasible to conduct the study. However, we are aware that for proving this result, we need to conduct a multi-center sham control randomized trial. And also, although we did all this EEG, EKG sensory testing, we were not powered enough to see the differences. But however, we were interested to evaluate mechanistic biomarker, including autonomic signatures of analgesic response. Thank you. I'm taking questions.
We're gonna have to hold questions. Please try and talk afterward.
Sure.
Thank you very much. No more questions.
Hello, good morning. Thanks for the great talk. This is Yi Jen. I'm from Stanford. Very interesting.
Excuse me, we're going to hold questions until,
sorry.
if you could just speak afterwards. Sorry about that.
Of course.
The next talk is by Dr. Vitaly Protsky. He's the co-founder and CEO of Pandica. The talk is entitled A Window of Opportunity in the Treatment of Acute Pancreatitis.
And back. Right. Yes, thank you. Good morning. I'd like to express our gratitude for the opportunity to present our results, our work on the treatment of acute pancreatitis. There are numerous publications stipulating that strategic decisions made at early hours of hospitalization often determine the trajectory of this disease. This is often called the golden hours. We prefer the term the window of opportunity, and that's what I'm going to talk about. Unfortunately, and everybody who manages this difficult disease, we often miss this window of opportunity, and there are objective, sometimes subjective reasons for that. We often wait for complications like MODS to develop before we actually escalate the intensity and volume of treatment of intervention. Sometimes and often it is difficult to predict, to assess actual severity of patients or how the severity is going to develop because despite the availability of multiple recommended scoring systems, predictive parameters, etc., many of them are only informative after 48 hours. Many of them require parameters that are simply not available, for calculation, for use at early stages, within the first 24 hours. And surprisingly for me, many of them actually use different thresholds for the same parameter. So using different scoring systems, you can arrive at different conclusions in terms of severity or predicted severity. The treatment of acute pancreatitis, despite all the progress that undoubtedly has been made over the years, remains reactive and largely supportive. And that has been the motivation for us, for our team, to develop the Pandica platform shown here. It's the catheter on the left, which is designed to act on multiple pathophysiological processes that cause or drive acute pancreatitis at the same time. The device, and that is a catheter, is placed endoscopically, which is a kind of routine endoscopic procedure, easily implementable in standard clinical practice. Placed in the duodenum. When it is there, it isolates and decompresses the segment, the area around the papilla. By doing so, we effectively we imitate the natural peristaltic suction that is lost in acute pancreatitis. This helps to drain bile, pancreatic juice, reduces the reflux of these biofluids into the ducts.
The fact that we block off stomach and intestine also prevents gastric and intestinal material entering duodenum, and by virtue of doing this, we reduce humoral stimulation of pancreas. We have evidence for that. During the procedure, we normally collect about 150, maybe 300 milliliters of biofluids, bile and pancreatic juice, instead of normal, kind of typical 2 liters that are produced daily. Further, the catheter allows for drainage and decompression of stomach and intestine, preventing potentially compartment syndrome. And it also allows simultaneously to initiate enteral feeding directly into the small intestine, bypassing duodenum. Again, reducing the chances of stimulating the function of pancreas, exocrine function of pancreas. In order to evaluate, not even to prove, to evaluate whether this functionality, this combined functionality is actually helpful in improving outcomes, we designed and conducted a clinical trial, a randomized, controlled, multi-center prospective clinical trial, which eventually enrolled 154 patients. This is the kind of rough design of the trial. Patients were randomized after screening, first stratified according to etiology, and we included both non-biliary and biliary, not requiring ARCP for biliary patients. Stratified patients were randomized in 1-to-1 proportion into 2 groups. Group 1, Pandicath plus standard of treatment. Group 2, just standard of treatment. For the inclusion or enrollment criteria, we focused on moderate and severe acute pancreatitis, or let's say non-mild. And for the kind of main measure of effectiveness, we chose a composite primary clinical endpoint incorporating majority of, let's say, bad events, negative events that can happen in acute pancreatitis, including obviously mortality, including development of MOTS, development of infectious, non-infectious complications. One of the challenges that we faced in a study, and obviously we would have the same problem in the clinic, is determining who actually was suitable in terms of the severity, in terms of being moderate and severe. I already mentioned that there are multiple scoring systems, and we used all of them. At least we followed all of them. Then, after the study was completed, we retrospectively analyzed how predictive they were in terms of identifying patients who did actually develop complications. And you can see that some of the parameters performed quite well. For example, BSAP doesn't do too bad a job, but it still misses about 40% of patients who did actually develop complications. Apache is the best in terms of its predictive power, but it can only be helpful after 48 hours, so not very helpful in our setting, but also in the clinic. Also, and as it happens, following most recent recommendations, we actually focused on clinical parameters like presence of SIRS, presence of local complications, especially in combination with SIRS, and of course presence of MOTS. And this retrospective analysis also shows that this combination can actually be a pragmatic choice in terms of effectively identifying patients with a higher risk of developing complications, but also avoiding overtreatment. So it's a reasonable balance of sensitivity and specificity. These are the results, or some of the results of the trial. We published results in Pancreatology about a year ago, and if you're interested, you can always look at the publication using the QR code. The study, I don't see it shows, I think certain things have moved. I don't know why. Well, you'll have to believe me. The study produced statistically significant improvement in the primary clinical endpoint, largely driven by major reduction in the incidence of infectious and non-infectious complications, and that's what we were actually aiming at. Also, quite importantly, I think it showed a very respectable number needed to treat parameter, very rarely reported, but in my view, probably the most clinically useful parameter in terms of evaluating, assessing the effectiveness of a treatment. Also, it may be worth noting that despite randomization, which we think was successful, group 1, the experimental group, was slightly more severe at the time of enrollment, based on a slightly higher incidence of patients with MOTS and SIRS. Despite that, after 96 hours of treatment, the positions reversed. So we actually see reduction and MODS for group 1, while in group 2, there are more patients with MODS. We also saw a reduction in the number of patients who required surgery and number of surgical procedures in group 1. And also we saw the reduction in the length of stay overall and length of stay in ICU specifically. Then, as part of sensitivity analysis that we did to demonstrate to ourselves that these results are independent from potential confounders, we discovered an interesting dependency. Specifically, time or time-related parameters such as time between disease onset and hospitalization, time between disease onset and ICU treatment, etc., had a very, very direct relationship with development of complications. It seems quite logical, but we saw it in numbers. The most striking dependency, the most striking predictive power, if you wish, was for the parameter describing time between hospitalization and ICU treatment. Very importantly, it is the parameter we can control. We decide when we place patient in the ICU. Further, when we analyzed data not just for the whole population, but also separately for group 1 and group 2, we discovered that specifically in the standard of treatment group 2, this relationship was very, very, very powerful. Every hour of a delay in terms of placing a patient in the ICU cost quite a number of percentage of increase of the risk of developing complications. In group 1, surprisingly, this relationship does exist, but it is very much blunted. This suggests, at least based on this data, that not only our device or the treatment based on our device helps improve on certain outcomes, it kind of widens the window of opportunity. So it basically allows more time for active intervention. The conclusions based on this analysis are relatively simple. We do believe that time should be treated as a modifiable risk factor. It should be evaluated and actually used in this context. We saw in our own experience that use of clinical parameters like source, local complications, and MODS can be very helpful in identifying patients at higher risk of complications and those who require earlier intervention. And finally, as already said, we have good evidence. Obviously, it's not final, not conclusive. More research is required, but we have good evidence that our technology, our method of treatment provides benefits in terms of improving outcomes, but also potentially in terms of widening the window of opportunity. To finish, I would like to obviously thank all my colleagues, our small, very small, but very dedicated team. Without them, this study and everything we do would not be possible. And on a personal note, every journey starts with a single step. Alexei Kashintsov, who sits here in the audience, who actually invented this technology and pioneered it. 13 years ago, he got a grant. He was supported by APA, by Hirschberg Foundation, to come to Miami for a similar conference. And at least he tells me that the impressions, the ideas he got there became the driving force for the work that we've been doing and results we've been presenting. Thank you.
Unfortunately, we have to skip the questions. I want to remind to everyone again, we have only 10 minutes left. That includes the presentation as well as questions. So if we can be on time, we will have some time left at the end for questions. So our next speaker is Yana Chai from Peking Union Medical Hospital. The title of the talk is Functional Characterization of Pancreatic Collagen Expressing Fibroblasts in Mouse Acute Pancreatitis.
We thank APA for the opportunity to present our work. We have none to disclose. Pancreatic fibroblasts are major stroma cells in the pancreas, commonly considered exchangeable with pancreatic stellate cells. They are quiescent during homeostasis, provide structural support by producing extracellular matrix proteins. They can be activated in inflammation and cancer. They are key mediators in chronic pancreatitis. They have unclear role in acute pancreatitis. Our study object one is to genetically label fibroblasts in the pancreas and track their fate via lineage tracing during AP using model 1. Collagen Y2 ER tomato mouse, which was produced by crossing collagen Y2 ERT mouse with TD tomato reporter mouse. Cree recombination was induced by tamoxifen injection for lineage tracing of fibroblasts. 2 to 3 days later, pancreas and other vital organs were harvested for analysis. In a separate set, AP was induced by 9-hourly cerulean injections. Pancreas and blood were harvested 1, 24, and 48 hours after the last cerulean injection for analysis. In normal pancreas, upon tamoxifen injection, TD tomato positive pancreatic fibroblasts consist approximately 13% of total pancreatic cells. TD tomato positive cells are barely detectable in control mice injected with corn oil. Immunofluorescence was performed using desmin, a pancreatic stellate cell marker, demonstrated that 50% of TD tomato positive pancreatic fibroblasts were desmin positive. Using PNA, peanut agglutinin, a pancreatic acinar cell marker, and the CD31 and the celiac cell marker, revealed no overlap between TD tomato positive and the PNA or CD31. Pancreatic fibroblasts then isolated and in vitro stained with oil red, a marker of quiescent pancreatic stellate cells. Most of the cells were oil red positive, among which 35% were TD tomato positive. Other organs were reviewed with various numbers of TD tomato positive fibroblasts, ranging from remarkably high in colon, 33%, lung, 65%, skin, 52%, to low in heart, 5%, kidney, 5%, and liver, 1%. After AP induction, TD tomato positive pancreatic fibroblasts showed a time-dependent increase, paralleled with increased AP score. Increased amylase level was only observed at 1 hour. Immunofluorescence using alpha SMA, a marker for activated fibroblasts, and Ki67 on the bottom, a cell proliferation marker, demonstrated time-dependent increases of double positive cells of TD tomato with alpha SMA and Ki67. To understand the role of pancreatic fibroblasts in AP, our objective 2 is to deplete the fibroblasts and evaluate the effect on AP using model 2. Collagen Y2 Cree DTA mouse, which was produced by crossing collagen Y2 Cree ERT mouse with diphtheria toxin A mouse. Cree recombination was induced by tamoxifen injection for depletion of fibroblasts. 2 days later, AP was induced. Pancreas and blood were harvested 17 hours after the last cerulean injection for analysis. Compared to sibling control, collagen Y2 Cree DTA mouse showed no significant increases of amylase level, total AP score, as well as scores of pancreatic edema and necrosis. However, inflammation score was significantly increased. We therefore measured the several inflammation markers and found that MR levels of IL-6 and the COX-2 was significantly increased. We conclude that fibroblasts can be tracked in the pancreas and other organs using collagen Y2 Cree TD tomato mouse model, indicating its potential for studying diseases in the pancreas and other organs. Pancreatic fibroblasts are a subset of pancreatic stellate cells. They can be activated and proliferate during AP. Depletion of pancreatic fibroblasts exacerbates AP inflammation, suggesting a potential protective role of pancreatic fibroblasts in AP. Further investigation into the mechanisms underlying the protective role in AP is warranted. Thank you.
We have time for one or two questions if anyone has a pressing question.
Rishi Mukherjee from Liverpool. Thank you for your presentation. I was wondering, with regards to the role of the fibroblasts within the acute inflammatory phase, do you have any data or any understanding as to whether they may have a more active role or just be bystanders in the process, with other inflammatory cells more likely to play a much more major role, such as neutrophils, for instance, that we have a much better understanding of?
That's a great point. We don't have data now, so we are going to do as a future direction. Thank you.
Okay, the next talk is by Karianne Feld from the University of Bergen. The MODY-8 mouse, a model for studying sex-specific differences in chronic pancreatitis.
So, good morning, everyone. First of all, I would like to thank the organizers for giving me this opportunity to present new results from the cell group here today. So, carboxylester lipase, or CEL as we call it, is a digestive enzyme mainly expressed by the exocrine pancreas. There are two pathogenic variants that has been published. It's the cell hybrid variant that is a genetic risk factor for chronic pancreatitis, and I will come back to that in the end of my talk. And then it's the cell MODY variant that causes a combination of chronic pancreatitis and monogenic diabetes, also known as MODY-8, and this is, the focus of this talk. So the cell gene consists of 11 exons, and in the last exon, it encodes for a variable number of tandem repeat, or a VNTR. And these repeats can be, the number of repeats vary between 7 and 23 in the normal population, with 16 being the most common, as illustrated here in these blue squares on top. So cell MODY is caused then by a mutation in the VNTR. So as illustrated here in these cell MODY families, you can have a mutation in the first, in the fourth, or in the fifth repeat. The result is a truncated C-terminal, and the amino acids are altered. And based on cellular study, we see that the more proximal the mutation, the more severe is the effect. And so these are the 5 families that has been published so far, but we also know about 4 others. So there are more MODY families out there. Then to the effect. The effect is linked to protein misfolding. So compared to the normal protein that is nicely secreted out of the acinar cells, the cell MODY variant with this truncated C-terminal, it leads to impaired secretion, the protein aggregates, and you get increased ER stress. So it follows this misfolding dependent pathway in chronic pancreatitis. So in addition to cells studies, we have developed a mouse model, and here we see that the heterozygous mice develop chronic pancreatitis spontaneously, with inflammation, fibrosis, and fatty replacement, as well as increased ER stress, and also we see changes in the ER, in the cell protein expression pattern. So the exocrine, and we studied the mice from 1 to 12 months, and we see the exocrine changes already at 1 month. But when it comes to the endocrine phenotype, there is no sign of diabetes development, either at 6 months or at 12 months. It's rather the opposite, that the cell-modi mice seems to be more glucose tolerant. We looked more closely into the islets, and then we see that when it comes to the glucagon-producing cells and the proliferating beta cells, there is no changes between the modi mice and the controls. But when we look at the number of islets and the total islet mass, it increases for the modi mice at 12 months compared to the controls. So the islet seems to compensate in some way. We also made the mice homozygous, but there was still no sign of diabetes development. However, the homozygous mice had a much more severe pancreatitis, I guess as expected, both when it comes to inflammation and also acinar atrophy, and we saw that both for the male and the female mice. And also, interestingly, we saw cyst formation, and actually we could see it with the naked eye, as illustrated here. You see on top there, the arrows points to clear spots in the isolated pancreas. And this is the worst extreme case, where the whole pancreas was filled with cysts. And when doing this work, I got the impression that the female mice presented with more cysts than the male mice. So we have now quantified it, and it's a borderline statistical significant increase in cyst formation for the homozygous female mice compared to the male mice, which we think are interesting, because when you go back to the patients, pancreatic cyst formation is one of the clinical features that you see, as illustrated here on these MRIs, both from a male and a female patient. And these MRIs are from a paper back in 2014. And here they investigated or looked into 14 cell-modi carriers. I'm not touching anything. Yeah. And yeah. And in the lower part, okay, so this is working. Okay. So in the lower part, you see, so there were 13 cell-modi carriers. 8 of them had developed diabetes, and then which are in the red square. And then you see when the diabetes development, the cyst formation also appears, and it seems, and it also increases with age and diabetes duration. And also, if you look at the red arrows, these are the females, and then they present with the largest number of cysts. So this is, of course, a limited number of patients, and we are now excited to have the Norwegian Modi families back into our clinic early next year to look more closely into these things. Yes, and this is also another female patient with extensive cyst formation. So then, to sum up, the homozygous mice present with a much more severe exocrine phenotype than the heterozygous mice, but there was no sign of diabetes development for none of these strains. The female mice present with more pancreatic cyst, and we also see lower body weight and lower white adipose tissue mass for these animals. And also we saw the link into these female MODY 8 patients with also more cyst formations. So there seems to be sex-specific differences in the MODY8 pathogenesis. And we think that's interesting because when you look at cell as a digestive enzyme, in addition to being expressed by the acinar cells of the pancreas, it is also expressed in the lactating mammary glands. So it's an important part of mother's milk and important for the digestion of lipids in newborns. And with that, it's most likely regulated by female hormones. And we have preliminary data now indicating that cell expression can be regulated by estrogen. And we also have some nice genetic data indicating that the cell hybrid variant, which is a risk factor for chronic pancreatitis, predominantly affects females. So still a lot of things to do when it comes to cell research, so to be continued. And I would like to thank this Bergen Cell Group, especially Professor Anders Molven and PhD Anne Gravdal, and our collaborators in St. Louis, Mark Love and Sunjun Xiao, and their group, Caroline Verbeke for scoring, histological scoring, and our consultant in Bergen, Erling Chora, for seeing the patients, and our funding, of course. Thank you for your attention.
We have time for one brief question.
Quick question. Is it known what drives expression in mother's milk versus the pancreas? Is the same promoter, same transcription factors, or it's a completely different mechanism?
When you look into the cell promoter, there are different regulator sites there that are specific for the mammary gland and for the pancreas. And when it comes to the estrogen receptors, there are binding sites both for the estrogen receptor alpha and beta. Alpha is specific for the breast, whereas we speculate, but it's not much known about it, that the beta variant is the one driving the acinar cells.
Thank you. Our next speaker is Cole Myers from University of Minnesota. The title of the talk is Metabolic Outcomes Following Isolate Transplantation Using the Omental Patch Technique, a Randomized Controlled Study. Green to evidence, red to back.
Good morning. I want to thank the APA Organizing Committee for the opportunity to speak today. I'll just go, and I have no financial disclosures. Total pancreatectomy with islet autotransplantation, or TPIAT, is a well-established therapy for patients with debilitating chronic pancreatitis. Previous studies demonstrate its efficacy in improving pain outcomes while sustaining improved quality of life due to mitigating the development of type 3C brittle diabetes. Traditionally, islets are infused into the liver via the portal vein. However, interportal delivery has several limitations, necessitating identification of viable alternative sites. Limitations include the instant blood-mediated inflammatory reaction, or IBMIR, exposure to low oxygen tension, and a poor glucagon response to hypoglycemia, among others. The omentum has been proposed as an alternative site, is highly vascularized, offers large capacity, and is easily accessible for graft monitoring postoperatively. Our group and others have previously demonstrated the technical feasibility of omental pouch transplantation. However, functional metabolic outcomes relative to standard islet delivery alone have not been previously investigated in human trials. The primary goal of this randomized control study was to assess islet engraftment and endocrine function 1 year postoperatively among those undergoing the combined omental pouch and interportal transfusion, compared with the interportal islet delivery alone. We specifically evaluated 3 metabolic endpoints at 3 months and 1 year. We looked at beta cell function, islet cell mass, and alpha cell function. We also assessed islet engraftment via biopsies at 1 year. Patients undergoing total pancreatectomy for chronic pancreatitis were randomized intraoperatively to receive intraportal or omental pouch islet auto transplantation. Patients who met clinical inclusion criteria with adequate islet yields were included in the analysis. At 1 year, 5 patients successfully completed minimally invasive omental pouch biopsies, allowing assessment of islet engraftment. Insulin response and glucose disposal to oral glucose load was assessed using a mixed meal testing tolerance testing. The insulin response to hyperglycemia was assessed using the intravenous glucose tolerance testing, or IVGTT, and beta cell mass was assessed directly after IVGTT using glucose potentiated arginine stimulation testing, or GPASE. As these tests involve multiple measurements, they're reported over multiple measurements over a short time period. The results are presented as the area under the curve at 3 months and 12 months. Hypoglycemic clamps were also performed at the 1 year time point to assess alpha cell function. C-peptide and glucagon levels were measured during sustained hypoglycemia at 70 milligrams per deciliter and 50 milligrams per deciliter. The differences in C-peptide and glucagon at the 50 step from the 70 step was used to measure islet response to alpha cell response to hypoglycemia. While arms were sex-balanced, patients randomized to the interportal-only group were slightly younger. Weight-standardized islet yields were greater among the controlled arm, resulting in a higher average islet equivalents transplanted interportally compared to patients randomized to the combined approach. There were no significant differences in Clavien-Dindo grade 3 complications, portal thrombosis, or other safety outcomes during the immediate postoperative period. Graft histopathology did not demonstrate visible islets, and there was no evidence of beta cell function at the omental site based on insulin staining. As you can see, there was no significant difference in A1C nor daily insulin requirements at either time point. And when you look at the mixed meal testing, there was also not a significant difference in the glucose elevations or beta cell response following an oral glucose challenge at either time point. The dashed line represents the average among a small cohort of healthy volunteers that also underwent testing. Similarly, there was no significant difference in beta cell response to hyperglycemia when doing the IVGTT. And lastly, beta cell mass was also similar between the two groups. When looking at alpha cell function, insulin suppression and glucagon secretion in response to hypoglycemia did not suggest any difference in alpha cell function at 1 year. This is supported by Clark scores derived from patient-reported hypoglycemic symptoms at both time points. In conclusion, in this randomized controlled study, omental pouch islet autotransplantation resulted in poor long-term engraftment, while findings suggest that beta cell function was diminished among patients that underwent the combined approach. This may be confounded by imbalanced islet yields among the two arms. Beta cell mass and alpha cell function were not statistically significant. Differences were not statistically significant. Given these findings, there is a continued need to explore other candidate alternative sites for islet transplantation after total pancreatectomy. Thank you, and time permitting, I'd be happy to take any questions.
No way. Dr. Guria, you go first. Okay, so just a quick question. My son, Abuel Haja, Cincinnati Children's, wonderful job. We need more of these studies in the TPIT world. Wondering why the two arms were both involving intraportal, which I know traditionally that's what we do. I mean, are we ready to say purely an arm of omental versus intraportal? But that's more kind of provocative. I actually have a question about the mix of the islets. So compared to the traditional intraportal, the 5 ml pellet in 200 and the classic heparin amount that you add, did you adjust for any of that in the group that went for the omental in terms of preps?
We mostly just adjusted for the islet equivalents isolated, just with a small sample size. We did not.
Yeah. So it was not more condensed if you had the omental pouch. Okay. Melina is nodding her head. It's good. We all need to learn from this.
So Cole did a beautiful job, but you weren't there when we designed the study, so I can also address a couple of those things. I think the islets Greg put in the omentum, that particular part of it wasn't in 200 mils. That was actually sedimented, as I recall, to put in the omentum, unless you remember something different, Cole. But the islets that went into the liver were exactly the same. So same prep for the liver, slightly different for the omentum. We did initially talk about this study as omentum versus portal. I was the one who said, I don't want to do that because I'm too nervous about whether or not this will be efficacious and then, you know, impairing outcomes in that patient population. So that was it would have been more interesting and more pure scientifically that way. I just was worried about the patients.
Yeah. No, congratulations, wonderful work.
Yeah, thanks. Great work. Juan Urrea from Cincinnati. Yeah, I don't think we have equipoise to just do mental without portal. Was there a specific percentage of the pellet volume that you've removed from the main to put it in the omentum, or you just had extra and put on those patients?
So we, what we defined as adequate islet yield was greater than 3,500 islet equivalents per kilogram. So when patients met that criteria and were randomized intraoperatively, we would give 3,000 interportally, and then the excess would go to the omentum.
Jamie Nathan, Nationwide Children's. Curious a little bit about the technical component of it, and maybe Melina can speak to that. Did you sew the pouch closed? Did you use fibrin glue? What were the sort of technical approaches to implantation in the omental pouch?
Yeah, so you take the greater omentum, you make a little bowl, and then you drip the islets into the bowl, and then you put a little fibrin sealant over it, and then you close with a running absorbable suture. Thank you.
Okay, our next talk is by Li Jiaoyu from the affiliated hospital of Qingdao University. It's entitled Liver Kinase B1 and CD11C positive macrophages inhibits fibrosis and chronic pancreatitis via the CCL2 CCR2 axis.
Good morning, distinguished chairman and the esteemed colleagues. I'm Li Xiaoyu. I come from the Qingdao University from China. So today I'm very grateful to have the chance to share our recent work titled Liver Kinase B1 in CD11C cells inhibit fibrosis in CP. As we all know, chronic pancreatitis is a long-term inflammatory disease characterized pathologically by progressive and irreversible pancreatic fibrosis. And this pancreatic fibrosis in CP is closely associated with the macrophage activation and its interaction with PSCs. LKB1 regulates immune systems by controlling immune cell fate. And our previous studies showed LKP1 suppresses Treg cells in multiple organs, but not in pancreas. So it's very interesting. CD11C, traditionally a DC marker, is now recognized as also identifying monocyte-derived macrophages. Across diseases, CD11C macrophages drive inflammation while pro-inflammatory cytokines. We found for the first time that fibrotic areas of CP accumulate large numbers of CD11C cells. Furthermore, these CD11 cells in CP tissues exhibit downregulated LKB1. Subsequently, we generated CD11C specific LKB1 knockout mice, which develop exacerbated pancreatic pathology and PSC activation compared to controls, confirming that LKB1 deletion in CD11C cells drives CP inflammation and fibrosis. RNA-seq reveals that LKB1 knockout altered the pancreatic cellular landscapes, increasing PSCs, macrophages, and T cells. Macrophages subtyping identify 4 distinct clusters. Notably, the CD11C CD206 macrophages subpopulation displayed the most significant expansion in LKB1 knockout mice. We confirmed CD11C CD206 macrophages were significantly increased in pancreatic tissues of LKB1 knockout mice compared to control. The same holds true for patients with CP. RNA-seq revealed that the LKB1 deletion markedly upregulated CCL2 in both CD11C CD206 macrophages and PSCs, and these findings was consistently observed in the CP patients. Next, we used this bidarate, a CCL2 inhibitor can abolish the exacerbated fibrosis in CP induced by LKB1 deletion, while alleviating pancreatic inflammation and fibrosis in both experimental groups. And a CCR2 antagonist also achieved a similar therapeutic effect. Therefore, we proposed that LKB1 deletion enhances infiltration of CD11C CD206 macrophages through the CCL2 and CCR2 axis. And RNA-seq data enabled cross-prediction of transcription factors, and revealing state 3 as a pivotal downstream effector of LKB1. To explore this mechanism, we differentiated 2 groups of mice, bone marrow-derived monocyte into CD11C cells, used GM-CSF. LPS-C2 emulation revealed that LKB1 deletion promotes CD11C expression in CD11 cells. This analysis confirmed that their co-localization. In vitro co-culture demonstrated that LKB1 deletion promotes CCL2 expression via state 3 phosphorylation, while upregulating fibrotic factors like TGF-beta1, indicating it drives CD11C CD206 macrophages polarization and pro-fibrotic function. To elucidate how PSC secrete more CCL2, cell chat analysis showed that LKB1 deletion augments CD11C CD206 macrophage PSC crosstalk with OSM from CD11C CD206 macrophages, acting on OXMR on PSCs as a key communicative bridge. Immunofluorescence further validated the specific location of OSM and OSMR. This result showed that in CP, LKB1 deletion in CD11C CD206 cells strengthens their interaction with PSCs via the OSM and OSMR axis. We co-cultured LKB1 deleted CD11C CD206 macrophage with PSCs, and LKB1 deletion promote OSM production and secretion in these macrophages. These macrophages induce significant PSC activation and CCL2 secretion. We treated PSC with recombinant OSM, And dose response and time course experiments shows OSM directly upregulate profibrotic markers. Next, we found that OSM neutralizing antibodies treatment blocks LKB1 deletion driver PSC CCL2 secretion and macrophage infiltration, elevating pancreatic inflammation and fibrosis. In conclusion, our study reveals novel mechanisms regulating fibrosis in CP. LKB1 deletion in CD11C cells promotes the infiltration of CD11C CD206 macrophage by enhancing CCL2 secretion and drives macrophage and PSC's interaction via OSM signaling, reprogramming PSC function and exacerbating fibrosis. And I would like to express my grateful for my teams for their hard work. And this is our teams, the clinical team and the physical research teams. That's all. Thank you for your attention. Thank you.
We have time for one or two questions, if anyone's.
Hi, thank you for your excellent talk. So I have one question regarding the population. So you identified CD11C positive, CD206 positive population, but we know that actually CD206 positive, these cells are M2 macrophage, and while CD11C positive are, we use it for M1 macrophage. So how do you explain the co-expression of this cell population in your study? Thank you.
Okay, thank you for your question. As we all know, there are classical M1 and M2 macrophages in CP tissues. So our study find that there is another kind of macrophages with the marker CD11C and CD206. So we find is not the same macrophages with the M1 and M2. It may be like a mixed type M1 and M2. That means it also has the functions like the M1 is a pro-inflammation factor, and it also have the functions like M2 is for fibrosis.
Okay.
So
thank you.
Thank you. Thank you.
Thanks very much.
Our next speaker is Lu Ke from Jindin University. The title of his talk is Triglyceride Lowering Therapy in Patients with Hypertriglyceridemia Associated Acute Pancreatitis and Extremely High Serum Triglyceride, an analysis from the PERFORM registry.
Good morning, everyone. So thank you for having me here. Today I want to talk about subgroup analysis from our PERFORM registry. So I have no relationship in this. So the incidence of hypertriglyceridemia-induced acute pancreatitis is extremely high in China, and it accounts for like 20% of more than the acute pancreatitis cases in China, which is not the case outside any part of the world. So it's a unique phenomenon, a lot of reasons, I'm not sure. Yeah, so, but we know that the triglyceride level at admission may be associated with the severity of the disease, and the study from the Mayo team shows that free fatty acid may play a role in the exaggeration of the disease. So there's a major aim during the early treatment of HTGAP is that we have to lower the triglyceride level, and there are several options. So we have medical treatment, and we have some broad purification modes like plasmapheresis. So the most commonly used broad purification model is still plasmapheresis. It's the same thing in and outside of China. This is our previous study, like summarizing the first findings of the PERFORM registry. So this is the eligibility criteria for the registry. We basically include patients with non-mild cases. They have some worrisome clinical features, and with triglyceride level more than 1,000. And what we found in this study is that plasmapheresis was not associated with improved organ failure, and even timely target reaching was not associated with the organ failure free days. That means we don't need to hurry in these patients to do plasmapheresis or to reduce the triglyceride with a lot of different treatments. But the problem is after the publication of that study, there were a lot of arguments, and I was challenged several times at different occasions because people think that it may work in different populations, like more severe patients, like patients with higher triglyceride level at the admission. And here's an observation study showing that in patients with like very high level of triglyceride at admission, they may benefit from plasmapheresis. And so the clinical question in this specific subgroup analysis is that whether timely triglyceride reduction will associate with improved outcomes in these patients. And the selected population is patients with extremely high triglyceride level, which is more than 4,000. And this is the flow chart of the study. So we have two cohorts. Cohort A was used to test the association between timely reduction of triglyceride and the clinical outcomes, and the cohort B was for the assessment of plasmapheresis effects. And this is the overall baseline characteristics. So the median triglyceride level at admission was very high. It's more than 6,000. The median part2 score was around 6. So they are not very sick patients, not all ICU patients, but with extremely high triglyceride levels at admission. And this is the result, the description of patients in cohort A. So even in these patients, with very high triglyceride level at admission, you can see still there were 27 patients had a triglyceride level lower than 500 at the third day of admission, which is very fast, even in these with really high triglyceride levels. So the reduction of triglyceride levels in these patients are like exponential. It's like very fast. And we did see that timely reduction of triglyceride was associated with improved outcomes in terms of the incidence of severe acute pancreatitis. And we can see other markers that showing some clinical improvement in these patients. And this is cohort B for the use of plasmapheresis. So you can see the patients who underwent plasmapheresis, they have more severe disease, they are more sick, and then patients receiving medical treatment. So there is some difference in the baseline severity of these patients. And here is the description of plasmapheresis sessions. For the majority of the patients, they received only one session, because there's a universal lack of plasma in Chinese hospitals because it was needed for like selective surgeries. So almost all the patients just received one session. This is a current practice. And this is the result. We did not see, and after confounding adjustment, we did not see any signs of clinical improvement with the use of plasmapheresis. And most important finding is that even in patients with like very high triglyceride level at admission, you did not see the use of plasmapheresis can accelerate the reduction of triglyceride, which was not as we imagined, because the plasmapheresis is like the procedure looks fantastic. You can have a large bag of oil outside of the machine, but it seems it did not affect the reduction of triglyceride level in these patients. So here are the conclusions from this study. So now we know that time reduction of triglyceride level, it was associated with improved outcomes in these patients, but the use of plasmapheresis was not, and it was even not associated with time reduction of triglycerides. So kind of pointless to do plasmapheresis in the patients. We are doing a large trial, so you will see the trial results next year, and this is a randomized trial, so we'll show how does it work. And this is a long-term running registry. The performance registry had recruited more than 1,000 patients all across the country, and we have published several studies in different subgroups, different folks, like the recurrence of the patients, and like patients with more severe, with organ failure, at early organ failure with extremely high triglyceride levels. And so this registry is open to everyone. I mean, we can establish an English interface like in no time. So everyone who are interested in this population, want to do something, you can visit our website or have a look at our X handle or email us. Thank you.
Thank you for the talk and sharing your data. I'm Vijay Singh from Mayo Scottsdale. So what was the anticoagulant that you used for the plasmapheresis circuit to keep this blood anticoagulated?
Actually, the anticoagulant therapy is kind of like a standard of care in most of these patients. They use low molecular weight heparin in most of the patients, but with a low dose. But you know, the Chinese population are like with moderate to low BMI. Most of our patients have the BMI between like 22 to 25. So the 4,000 dose of LMWH is not that low. It's like a prophylactic dose.
And this was only at the time of plasmapheresis, or
no? It's like usually if the patient was like undergoing plasmapheresis, they will be more cautious for the anticoagulant therapy because they don't want bleeding events. And if the patients receive exclusive medical treatment, the dose can be more ambitious.
Because conventional thing is that the extracorporeal circuit for plasmapheresis requires an anticoagulant.
Yeah.
And there are two anticoagulants. It's a citrate-based or a heparin-based. If you used a heparin-based, the reason I bring this up is heparin is also going to release lipoprotein lipase. And when you're going to release lipoprotein lipase, that diagram you showed from the Mayo group, which shows triglyceride lipolysis happening intravascularly, is going to get worse with that lipoprotein lipase. So therefore, you will reduce triglycerides but not have the benefit of it, just because of
it's a possible explanation. So what we see in no clinical benefits plasmapheresis, maybe it's because of the use of different anticoagulants. We'll see. We'll check all the data. Yeah.
Gubinsek has published on this. They have compared citrate to heparin and seen better outcomes with citrate.
Thank you. I will check that.
Hi, I'm Peter Hegyi from Hungary. Thank you for your presentation. So first of all, how many of your patients were diabetic? I mean, what we can see that this population, the rate of diabetes, the prevalence is much higher. And have you used insulin plus, if it was not diabetic, like glucose as well, to reduce the triglyceride level? And the other, my question is that have you thought about randomizing your patients? Because of course registry analysis is good, but when you would like to compare two groups, it's not exposure because you put it's the PACO format. Use PICO format because it's intervention. And in that case, you know, you can compare more correctly the intervention.
Thank you, Peter. I know your elephant trial, and so actually we just finished the recruitment of our large trial. We randomized 188 patients, and hopefully we'll see the results early next year. And in that trial, we have very strict intervention, like you have to reach the target to stop additional plasmapheresis. If it not reach the target, like 500, you have to do another session to reduce it. It's like a more strict session. And for diabetic patients, I cannot recall the exact number. I think it's not very high prevalence of patients with a previous history of diabetes. But the combination of insulin and low molecular heparin is like standard of care in Chinese medical treatment. Plasmapheresis was used at different sites, at the most, I guess, depending on the availability of plasma.
Thank you.
Thank you.
Hi, I'm Richard Waldron from Cedars-Sinai, and I'm no scientific expert on hypertriglyceridemia, but I can say the word. When you're doing plasmapheresis, you're not just removing triglyceride, but you're removing lipoprotein particles of various characteristics. some of them might be good actors and some might be bad actors. So my question is, have you given any thought to replenishing the good lipoproteins or some such approach?
This is a brand new idea for me. Actually, I don't know how to supplement good lipoprotein. Yeah, but we did measure the cytokine profiles, and we see some trend because the plasmapheresis procedure was not was unselectional, so it can be like remove a lot of good or bad things. But the session for plasmapheresis, it's a very short session, usually just like 2 hours. So I don't think it can remove a lot of the things, depending on how much plasma you use, of course. Thank you, but it's a nice idea. I may have a look, yeah.
Very quick comment. So in answering of Peter's question, in Chinese population, normally in our population, more than 10% patients are known diabetes before we diagnose acute pancreatitis, and then about 45% are with fatty liver diseases in Chinese population. Thank you, Peter.
Thank you for the addition. Thank you.
Okay. The final talk is by Bangwei Hong from Shanghai Hospital, Naval Medical University. Mechanism of lipid droplet protein ALB targeting CRBP1 and pancreatic stellate cells to alleviate pancreatic fibrosis.
Good morning, everyone. My name is Bangwei Huang from the Department of Gastroenterology of Shanghai Hospital in Shanghai. It's a great honor to share our recent work entitled Mechanism of Lipid Droplet Protein Albumin Targeting CRBP1 in Pancreas Stellate Cell to Elevate Pancreas Fiber Cells. Chronic pancreatitis, or CP, is a progressive fibroinflammation disease that can lead to long-term damage and even cancer. And pancreas stellate cell, or PSC, activation is essential to this process, characterized by the loss of vitamin A containing lipid droplet. However, how PSC loses this lipid droplet and become activated remain unclear. The loss of lipid droplet is accompanied by altered vitamin A metabolism. Its key metabolite, ATRA, inhibits PS activation. So we therefore wondered, could lipid droplet-associated protein regulate vitamin A metabolism and PSA activation? By integrating single-cell RNA sequencing and lipid droplet proteomics, we identified ALB as a key candidate. We hypothesized that ALB binding to CRBP1 to modulate vitamin A metabolism and suppress PS activation and fiber cells. First, single-cell sequencing revealed heterogeneity among PSA. A specific pollution class 4 was enriched in lipid and vitamin A metabolic pathway and showed the highest expression of ALB. ALB positive PSA exhibit higher lipid droplet accumulation. Next, we collect lipid droplet from both quiescent and activated primary PSA for proteomics analysis. Proteomics of PSA lipid droplet demonstrated that the activated PSA had decreased ALB and increased autophagy pathway. Immunofluorescence confirmed that ALB co-localized with lipid droplet but was markedly reduced in CP pancreas. This finding indicates the possibility that the loss of lipid-associated protein ALB probably is a feature of PSA activation and pancreatic fiber cells. We also examined serine from CP patient and the mouse model. This reveals that serine ATIE level will significantly reduce in CP compared with controls. Consistently, pancreatic tissue from CP mouse showed decreased expression of key vitamin A metabolic enzyme, including a disruption of retinol metabolism during pancreatic fibrosis. To assess whether AOB is functionally involved in vitamin A metabolism, we use AAV8 AOB. This increased AOB specifically in the pancreas and significantly attenuate pancreatic fibrosis with reduced collagen and alpha-SMA level. In parallel, we perform in vitro experiments using primary PSA, AOB knockdown in PSA, promote activation and decrease the expression of vitamin A metabolic enzyme while AOB overexpression restores their expression and suppress activation. So next, we explore whether AOB's protective effect depends on vitamin A metabolism. In mouse fed a vitamin A deficiency diet, pancreatic fibrosis would aggravate, while ATI supplementation alleviate. Importantly, AVH AOB treatment reverses fibrosis even under vitamin A deficiency, further demonstrating that AOB functionally links to vitamin A metabolism. To understand how AOB works, we perform onco-IP, cell staining, mass spectrometry, and spider assays. All approaches consistently confirm a direct physical interaction between AOB and CRPP1 in PSA. This finding was significantly reduced in activated PSA. Immunofluorescence also showed cytoplasmic colocalization of AOB and CRPP1. Moreover, AOB overexpression reduced autophagy-related lipid degradation, which means it may help protect lipid store and slow down cell activation. In summary, our study identified AOB as a novel lipid droplet-associated protein that may bind in CRPP1 to regulate vitamin A metabolism and suppress PSA activation. We are currently continue to investigate how AOB is regulated and whether it could be developed into a potential therapeutic approach. This research project is based on the chronic pancreatitis research team at Shanghai Hospital. I'm truly grateful to my mentors and labor mate at Shanghai Hospital. This project wouldn't have been possible without their support and collaboration. Thank you for your listening.
Thank you very much. Great presentation, Minoti Apte from Sydney. We do need studies like yours because that is the key question about why vitamin A lipid droplets are lost during stellate cell activation.
Yeah.
It was good to see that you're confirming earlier reports by Korean groups showing the necessity of albumin to be bound to the vitamin A to keep it within the cell. So I think that's, if you look up those older papers, you might see that. But I think what you've got more is the mechanism as to why they might be doing this. So the question for me is therapeutically, in what sort of chronic pancreatitis model would you use? And would you be able to show a difference after the fibrosis is already established?
Okay. Sorry, Professor, you mean what kind of CP model I use, yeah, right? Okay, I see. In the model, we use serine stimulating to watching CP and pancreatic fibrosis. We found the lipid droplet is lost. Yeah, maybe next question we can after my presentation we can talking more about this research. Thank you.
Hi, Suhail Hussain from Stanford. I also enjoyed your talk quite a lot. I guess it's novel because albumin is generally considered a carrier of at least retinoic acid, some of the vitamin A metabolites in the circulation, but not necessarily within the cell. There are, as you mentioned, CRBPs, FABPs, other intracellular carriers of vitamin A metabolites, but what you're suggesting is that the albumin somehow keeps the droplets intact and prevents the activation. I guess the design of your experiment, if I saw it correctly, is that you gave an AV albumin overexpression in vivo, and you're targeting potentially to the pancreas, but you're not necessarily targeting to the cells of the pancreatic, the PSCs or so on. Is it possible that the AV overexpression of albumin is just contributing more expression of albumin in the circulation, more retinoic acid delivery to the pancreas, and thereby mitigating the effect on chronic pancreatitis?
Okay. To be honest, actually, we also consider it that AOB might originate from serine because serine AOB expression is abundant, right? However, as early 2007, a paper published in the Journal of Gastroenterology, they found AOB is the endogenous protein and localized with the lipid droplet. And on the other hand, our data, both single-cell RNA sequencing and lipid droplet proteomics both showed AOB is reduced in CP and it's highly expression in the quiescent PSA. You mean can AOB be a therapeutic approach to cure CP, right?
Well, maybe we can talk offline. I was just talking about the design of your experiment. You're overexpressing albumin using a AAV vector, but it's not necessarily targeted to a particular cell.
We are continuing to investigate, and we are now building CP model, and gene can knock down in PSA. Thank you.
Thank you all attending. This concludes our session.